Imagine your kidneys are like a sophisticated water purification plant for your body. Inside this plant, there are millions of microscopic filters working around the clock. These tiny, intricate filters are called glomeruli. Each glomerulus is a tangled ball of tiny blood vessels, or capillaries, that acts as the kidney's primary filtration unit. Its main job is to filter your blood, letting waste products and excess fluid pass through to become urine, while keeping essential proteins and blood cells in the bloodstream. Think of it like a high-tech coffee filter, carefully separating the coffee grounds, waste, from the precious liquid coffee, or clean blood that you want to keep. This process is absolutely vital for maintaining the body's delicate balance of fluids and electrolytes. The structure of the glomerulus is perfectly designed for this filtering task. It sits inside a cup-shaped sac called Bowman's capsule. Blood enters the glomerulus under pressure, which forces water, salts, and waste products like urea and creatinine out of the capillaries and into Bowman's capsule. Larger molecules, such as albumin and red blood cells, are too big to pass through the healthy filter and therefore remain in the blood. This selective filtration is the first crucial step in urine formation. Every single day, your glomeruli filter about 200 quarts of blood to produce about 1 to 2 quarts of urine, a truly remarkable feat of biological engineering. So what is glomerulonephritis? Let's break down the word. Glomerulo refers to the glomeruli. Nephro is Greek for kidney. And itis means inflammation. Putting it all together, glomerulonephritis is simply inflammation of the glomeruli. When these tiny filters become inflamed, they can't do their job properly. The inflammation damages the delicate capillary walls, making them leaky. This is like punching holes in our coffee filter. Now, things that should have stayed in the blood, like proteins and red blood cells, start leaking out into the urine. This is the fundamental problem in all forms of glomerulonephritis. Understanding this basic function and dysfunction is your first step to mastering this topic for the NCLEX. The inflammation can be triggered by various causes, but a common culprit is the body's own immune system. Sometimes, after an infection or due to an autoimmune condition, the immune system gets confused and mistakenly attacks the healthy glomeruli. This immune-mediated damage sets off a chain reaction that leads to the classic signs and symptoms we see in patients. In the next section, we'll dive deeper into exactly how this friendly fire from the immune system happens and wreaks havoc on these essential kidney filters. The most common trigger for acute glomerulonephritis, especially in children, is a recent infection, often from group A streptococcus, the same bacteria that causes strep throat or skin infections like impetigo. Here's the sequence of events. First, the body fights off the strep infection by producing antibodies. These antibodies are like guided missiles designed to find and neutralize the bacteria. They attach to bacterial antigens, forming what we call an immune complex. In a normal response, these complexes are cleared away by the immune system. But sometimes these sticky little complexes travel through the bloodstream and get trapped in the tiny winding capillaries of the glomeruli. Once these immune complexes get lodged in the glomerular filter, they trigger a powerful inflammatory response. Think of them as unwanted squatters setting off a security alarm. The body's defense system, specifically the complement system, is activated. This system releases a cascade of inflammatory chemicals and calls in reinforcements, like white blood cells, neutrophils, and macrophages, to the site. These cells arrive ready for battle, but instead of fighting a pathogen, they begin to attack the glomerular tissue itself. This process releases enzymes and free radicals that damage the delicate glomerular basement membrane, causing swelling and scarring. This inflammation leads to two key problems. First, the damaged filter becomes much more permeable, or leaky. The holes in the filter get bigger, allowing red blood cells and proteins to escape from the blood and spill into the urine. This is why patients have hematuria, blood in the urine, and proteinuria, or protein in the urine. Second, the inflammation and cellular buildup can clog the filter, reducing the kidney's ability to filter waste. This clogging decreases the glomerular filtration rate, or GFR, which means less fluid is filtered out. Consequently, waste products like bun and creatinine build up in the blood, and the body retains excess fluid and salt. This entire process is a classic example of a type 3 hypersensitivity reaction. It's not the infection itself that directly harms the kidneys, but the body's overzealous immune response that occurs about 1 to 2 weeks after the initial infection has resolved. This time, lag is a critical clue in diagnosing post-streptococcal glomerulonephritis. The same mechanism can occur with other infections or in autoimmune diseases like lupus, where the body creates antibodies against its own DNA, forming complexes that deposit in the kidneys and other organs. Understanding this pathway is crucial for your exams and for patient education. When the glomeruli are inflamed and leaking, the body sends out clear distress signals. One of the most classic signs you'll see in your nursing practice is edema or swelling. This often starts as periorbital edema, puffiness around the eyes, which is most noticeable in the morning. As the condition progresses and more fluid is retained, this can become generalized edema, affecting the hands, feet, and abdomen, or ascites. This swelling happens because the damaged kidneys can't get rid of excess sodium and water, and the loss of protein, specifically albumin, in the urine reduces the osmotic pressure that normally keeps fluid inside the blood vessels. Another hallmark symptom is a change in the urine itself. Hematuria, or blood in the urine, is common and causes the urine to appear dark, smoky, or cola-colored. This is due to red blood cells leaking through the damaged glomerular filter. You will also see proteinuria, but typically in the nephritic range, which is less severe than in nephrotic syndrome. The combination of fluid retention and hormonal changes can lead to hypertension, or high blood pressure, which is a major concern as it can further damage the kidneys and cardiovascular system. Finally, as the GFR drops, the patient may experience oliguria, which is a significantly reduced urine output, less than 400 milliliters per day. While post-streptococcal glomerulonephritis is a common acute form, there are other types to know for the NCLEX. Goodpasture syndrome is a rare but severe autoimmune disease where the body creates antibodies that directly attack the basement membrane of the glomeruli in the kidneys and the alveoli in the lungs. This causes both glomerulonephritis and pulmonary hemorrhage, or bleeding in the lungs. Another critical type is rapidly progressive glomerulonephritis, or RPGN, an aggressive syndrome characterized by a swift decline in kidney function over days to weeks. It's a medical emergency that, if left untreated, almost always leads to end-stage renal disease. Confirming a diagnosis of glomerulonephritis involves piecing together clues from the patient's history, physical exam, and key lab tests. The first stop is a urinalysis, which will reveal the telltale signs, hematuria, proteinuria, and red blood cell casts. These are microscopic structures formed in the tubules. To check for a recent strep infection, a blood test for anti-streptolysin O, or ASO titer, is ordered. An elevated level confirms a recent exposure. Kidney function labs are essential. You will see an elevated blood urea nitrogen or BUN and serum creatinine indicating the kidneys are not filtering waste effectively. A decreased GFR will quantify this loss of function. In some cases, a kidney biopsy may be performed to examine the glomerular tissue directly, which is the definitive way to identify the specific cause and severity. The management plan focuses on treating the underlying cause, managing symptoms, and preserving kidney function. For post-streptococcal GN, the primary infection is often already gone, so antibiotics are only given if an active strep infection is still present. The core of management is supportive care. This includes strict monitoring of fluid intake and output, daily weights to track fluid status, and enforcing sodium and fluid restrictions to control edema and hypertension. Diuretics, like furosemide, are often prescribed to help the body get rid of excess fluid. Antihypertensive medications, such as ACE inhibitors, may be used to control blood pressure and reduce proteinuria. Your role as a nurse is central to managing these patients. Patient education is a huge NCLEX topic. You'll need to teach the patient and their family about dietary restrictions, the importance of taking medications as prescribed, and how to monitor for worsening symptoms like increased swelling or shortness of breath. For severe cases like RPGN or when acute kidney injury develops, treatments like corticosteroids, immunosuppressants, plasmapheresis to remove harmful antibodies, or even dialysis may be necessary. For memory, remember the acronym HAD-STREP, hypertension, ASO titer positive, decreased GFR, swelling or edema, tea-colored urine, recent strep infection, elevated BUN and creatinine, and proteinuria. Prevention is also key. The best way to prevent post-streptococcal glomerulonephritis is to ensure that all streptococcal infections, especially sore throats and skin infections, are treated promptly and completely with a full course of antibiotics. This stops the prolonged immune stimulation that leads to the formation of those damaging immune complexes. For your exams, focus on recognizing the classic signs, understanding the difference between nephritic and nephrotic syndromes, and knowing the cornerstone nursing interventions, monitoring fluid balance, managing blood pressure, and providing patient education. Mastering these concepts will set you up for success on the NCLEX and in your future clinical practice.